Okay, it's already 10 a.m. I think we can start now. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Okay, today I welcome to all of you to our seminar today, Seminar Virology. I also welcome our supervisor for today, Dr. Chan Yudin. Thank you for spending your time with us today. And this is the contents for our seminar today. The first is infectious mononucleosis and roseola infantum. Second is mumps, measles, and rubella. Third is varicella and herpes zoster. And last but not least is hand, foot, and mouth disease. My name is Hanis binti Hamdan with metric number 1810816, and I will present about infectious mononucleosis and roseola infantum. This is the outline for my presentation today. Okay, first, the definition of infectious mononucleosis. Infectious mononucleosis is characterized by a triad of fever, tonsillopharyngitis, and lymphadenopathy. It is also known as glandular fever. It is also known as glandular fever in the past, but for now, it is the term changed to infectious mononucleosis. Next is etiology. More than 90% of cases are caused by Epstein-Barr virus. Epstein-Barr virus is a double-stranded DNA virus. It is also a member of gum herpes virus. About 5 to 10% of infectious mononucleosis cases are caused by cytomegalovirus, Toxoplasma gondii, adenovirus, hepatitis virus, primary HIV, and possibly rubella virus. Next is epidemiology. Epstein-Barr virus infects more than 95% of world's population. As for age aspect, infectious mononucleosis primarily is a disease for young adults, but it also can infect childhood to older age. And the peak incidence for infectious mononucleosis is between 15 to 24 years old range. As for its socioeconomic status, it is usually occur in developing countries and ranges from 25 to 50% for lower socioeconomic groups. This is due to intense personal contact and poor personal hygiene among the children. The transmissions for infectious mononucleosis, it is being transmitted from person to person via salivary secretions. It also can be transmitted via sexual intercourse. But as for children, it being transmitted via salivary secretion. Next is pathogenesis. As we know, the Epstein-Barr virus is shed in salivary secretions for about 6 months from the following infection. After that, it is being transmitted from a person to another person via salivary secretions. Once the virus get contact with oropharyngeal epithelial cells, it will be replicated and the Epstein-Barr virus will be released into the oropharyngeal secretions. After that, the virus will infect the B cells in oropharynx. This will cause the pharyngitis clinical manifestation to occur. After that, the virus will induce the antibody production and activate the T cells in order to release the cytokines such as interleukin-2 and interferon gamma that will cause the fever to occur. After that, the infection will disseminate throughout the lympho-reticular system that will cause splenomegaly and lymphadenopathy to occur. After that, the virus can remain latent in B cell. Next is clinical manifestation. The incubation period for infectious mononucleosis is 1 to 2 months. As for prodromal period, it will last for about 1 to 2 weeks. Prodromal period occur after incubation period. Okay, during this phase, the pathogen will continue to multiply and the host will begin to experience Signs and symptoms typically due to the activation of the immune system. And the typical features for infectious mononucleosis is lymphadenopathy. Lymphadenopathy usually occur in all patients. Fever happen to 98% of patients, and pharyngitis occur to 85% of patients. The patient also may come with malaise, headache, fatigue, myalgia, abdominal pain, and nausea without vomiting. As for lymphadenopathy, it more commonly involves bilateral posterior cervical and posterior auricular nodes. And this is the position for posterior auricular nodes and posterior cervical nodes. And the lymphadenopathy peaks in the first week, and then it will gradually subside for over 2 or 3 weeks later. As for sore throats, it usually accompanied by pharyngitis and tonsillar exudates. And the exudates for the tonsil may appear white, grey-green, or even necrotic. The patient also may have fatigue. The fatigue may be persistent or severe. The fatigue also will resolve more slowly and persisted in 13% of patients for 6 months. The other clinical manifestation for infectious mononucleosis are splenomegaly and spleen rupture. Splenomegaly happen due to lymphocytic infiltration that will cause the spleen to enlarge beyond the protection from the ribcage. And this is the picture of splenomegaly. And the spleen rupture is a rare condition, but it is a life-threatening condition. As for rashes, infectious mononucleosis patient usually come with sore throat clinical features. Therefore, the clinician suspected that the patient have streptococcus infection. Therefore, they will be administered with antibiotic treatment. But it happened that actually the patient has infectious mononucleosis disease instead. Therefore, the drug allergy will happen, and this will cause the development of rashes. The type of rashes that can develop in infectious mononucleosis patient are generalized maculopapular rash, urticaria rash, and petechial rash. Next is differential diagnosis. The first, it can be infectious mononucleosis-like illness that can be caused by cytomegalovirus, Toxoplasma gondii, adenovirus, hepatitis virus, HIV, or possibly rubella virus. As for cytomegalovirus and HIV, it is almost impossible to differentiate them from infectious mononucleosis. Therefore, we need to do further diagnostic lab tests in order to confirm the diagnosis. Second, it may be streptococcus pharyngitis. This is caused by group A streptococcus. As for streptococcus pharyngitis, it also can present with clinical features of fever, lymphadenopathy, as well as pharyngitis, but it is not usually accompanied by significant fatigue or splenomegaly and examination. The mononucleosis syndrome also can be caused by drugs induced, such as anticonvulsants, which is phenytoin and carbamazepine, or antibiotics like isoniazid or minocycline. Next is investigation. We can do full blood count. In full blood count, we expect the patient to have leukocytosis and lymphocytosis. Lymphocytosis happen due to increase of a typical lymphocyte. Some of patients also may have thrombocytopenia. Next, we also can do liver function tests. Most of the patients, we expect that they have elevated serum transaminase. Full blood count and liver function test is functioned in order to support that the patient have EBV infection. But in order to confirm the diagnosis, we have to do monospot test and serological test. Serological test, monospot test is functioned in order to detect heterotrophite antibodies. If the patient undergo monospot test and already have positive result, we doesn't need to do serological test. But if the patient is suspected with infectious mononucleosis, but the patient have negative result for monospot test, we have to further with serological test in order to confirm the diagnosis. The serological test is functioned in order to detect viral capsid antigen, early antigen, and EBV nuclear antigen. Next is complications of infectious mononucleosis. First, patient may have airway obstruction. Usually, airway obstruction is due to nasopharyngeal tonsil hypertrophy and inflammatory edema of the surrounding soft tissue. This can cause the patient to have breathing difficulty. Next, the patient also may have splenic rupture, but this is a very rare case, but potentially lethal and a life-threatening condition. Another uncommon complications is nervous system problems. The patient can have headache, seizures, and ataxia. Next, the virus also may induce the red blood cell and white blood cell. Therefore, it can cause hemolytic anemia and aplastic anemia to happen. Another uncommon complications are myocarditis, interstitial pneumonia, pancreatitis, peritonitis, and orchitis. As for prognosis, most individuals with primary Epstein-Barr virus infection will recover uneventfully and develop durable immunity. Most acute symptoms will generally resolve in 1 to 2 weeks. Next is management. Okay. Actually, there is no specific treatment for infectious mononucleosis. But for the patient with infectious mononucleosis, we advise them to have adequate rest and encourage them to have enough fluid, drink a lot of water, and take a good daily nutrition intake. We can give symptomatic treatment to the patient, such as by giving antipyretic, acetaminophen, or non-steroidal anti-inflammatory drugs in order to treat fever, throat discomfort, and malaise. The patient also have to avoid physical activities during the first 2 or 3 weeks of illness or while splenomegaly is present. This is function in order to reduce the possibility of splenic rupture. As for patient with complication of airway obstruction, we can administer corticosteroid to the patient. Last is antiviral therapy is not recommended for the patient infectious mononucleosis. This is because antiviral has no effect on latent infection and there is no ability to cure the infection. The next topic I will explain about roseola infantum. Roseola infantum is a clinical syndrome characterized by 3 to 5 days of high fever that will resolve abruptly and is followed by development of rash. It is also known as exanthum subitum or sudden rash or SIDS disease. The etiology of roseola infantum, the most common cause is human herpes virus 6. Human herpes virus 6 is a large enveloped double-stranded DNA virus and it also a member of herpes virus family. Other causes of roseola infantum, it can be human herpes virus 7, enterovirus, adenovirus, and parainfluenza virus type 1. Next is epidemiology. As for age aspect, 90% of cases usually occur in young children younger than 2 years old. But the peak prevalence for roseola infantum occurs between 7 to 13 months. As for gender, it occurs equally for boys and girls. The roseola infantum is being transmitted by shedding of virus from saliva or respiratory droplets of asymptomatic adults or older children. Next is pathogenesis of roseola infantum. The infections begins after the patient come in contact with respiratory or salivary solutions from adults or older children who share the virus. After that, the virus will attach to the antigen-presenting cells, which are the dendritic cells. Then, the dendritic cell will be activated and migrated to the lymph node. At the lymph node, the dendritic cell will interact with T cell. Then the T cell will ingest the virus. The virus after that will be replicated and it replicates most effectively in CD4 T cells. In the T cells, the virus will further transcribe and translated to the new virus protein and then packaged to form a new virus. Once the new virus is ready, the T cell will undergo apoptosis and then destroyed. After that, the virus can infect other neighboring cells. The virus also can infect a broad range of cell types such as monocytes, natural killer cells, dendritic cells, astrocytes, and megakaryocytic cells. It also can enter the cell via interaction with CD46, which will give the virus broad tissue tropism. After primary infection, the human herpes virus 6 will remain latent in lymphocyte and monocyte. It will reactivate in immunocompromised and immunosuppression patients. Next is clinical features of Rhodiola infantum. As I explained earlier, the clinical course for Rhodiola infantum is 3 to 5 days of fever that will resolve abruptly and followed by development of rash. So during the febrile phase, it begins with a fever that may exceed 40 degrees Celsius, and this will last for about 3 to 5 days. And during the febrile phase, the patient also may have other clinical features such as palpebral conjunctivitis, this is palpebral, edematous eyelids, acute otitis media, Nagayama spots, rhinorrhea, cough, vomiting, diarrhea, bulging fontanelle, and also lymphadenopathy. Lymphadenopathy is common. After that, after the febrile phase, the patient may have maculopapular rash. Okay, as we can see, maculopapular rash is a faint pink rose-colored rash, and it is non-pruritic. The rash usually begins on the trunk, and after that, it will spread to the neck and proximal extremities. The rash usually lasts from 1 to 2 to 3 days, but it occasionally may come and go within 2 to 4 hours. As for differential diagnosis, the rash may be mistakenly that the patient have a rubella virus. This is because as for rubella disease, the rash begins from the face and then it will spread to the body. While for measles, there will be a presence of complete spot in the buccal mucosa. And for enteroviral infections, this is a hand, foot, and mouth disease, and this will be explained later by my friends. As for erythema infectiosum, the rash is more predominant at the cheek area. For scarlet fever, there will be sandpaper-like rashes at the patient. We also have to, it also can be caused by drug allergy. Drug allergy is an important consideration in children with fever, which are given antibiotic treatment, and then they will have drug allergy that will cause the development of rash. As for fever and pyorrhea, it may be mistaken that the patient have urinary tract infection. This is because urinary tract infection also may have fever and pyorrhea. Therefore, in order for us to differentiate the diagnosis, we have to do further lab tests in order to confirm the diagnosis. As for investigation, usually Rhodiola infantum is diagnosed clinically based on the characteristic of features, which is fever for 3 to 5 days that will resolve abruptly and followed by development of rash in children. But in order to confirm the diagnosis, we can do lab investigation such as full blood count. In full blood count, we expect that the patient has low neutrophil level that can cause neutropenia. Some of the patients also may have thrombocytopenia. We also can do urinalysis. We expect that the patient will have sterile pyorrhea. In order to confirm the diagnosis, we have to do PCR. This is because PCR function to detect the virus DNA. After that, we also can do serology tests. Serology tests are function in order to measure antibodies against the human herpes virus 6 and herpes virus 7 concentration. Last but not least, we can do viral culture. Viral culture is a gold standard method in order to document the active viral replication, but it has the disadvantages, such as viral culture is expensive. After that, time consuming and not readily available. It only available in research lab. As for prognosis of Rhodiola infantum, Practically all patients who are immunocompetent will survive roseola infantum without any sequelae. Okay, as for management, in most cases of roseola is benign and self-limited disease. So there is no specific therapy for roseola infantum, but we can give a supportive treatment, such as we treat the fever by giving antipyretics. We also have to make sure that the patient drink enough water, adequate food intake daily, especially for infants with diarrhea or vomiting clinical features. As for rashes, they will resolve without treatment. And that's all from me. Is there any question? If there's no,
Any questions for your friend? Yes or no?
I'm sorry, Doctor.
Everybody is not on camera right now. On your camera, so I want to see your faces. Okay, do you guys have any questions? Yes or no? Tak ada, Giling, kalau ada, say something. Everybody on your cameras, I want to see your faces. Everybody. Izzati, Hidayah, Afrina, Afika, Nurakila, Nabila, Anis.
I'm here, Doctor.
Everybody open on your cameras. I want to see. I want visual confirmation of you guys being here. Hidayah, Afika, Iza. Okay, the ones who cannot on the cameras, when I call out your name, you say here. Iza, Zahira. Everybody, keep quiet right now. When I call out the names one by one, be here. Hidayah. Hidayah. Iza, Zahira.
Yes, Doctor. I'll open my video now.
Hidayah. Hidayah. Oral confirmation. Are you there, Hidayah? Yes or no? Do anybody of you hear her? Or is this Hidayah, the UIA Hidayah? Is this your classmate? Or is this the staff? Tak dengar, Afina?
Classmate, Doctor.
Okay, where is she? You guys are 23? Act 23?
I will call her.
Tak payah panggil, maknanya dia tak ada kan?
I'm not sure if she has having audio problem or anything.
Okay, cannot be both audio and visual, isn't it? If it's audio and visual, then what is she watching or not?
I'm not sure, Doctor. Should I call her and ask or something? Okay.
Afika? Atira?
Yes, Doctor, but I can't open the camera. I can't. It's
Okay,
not.
never mind. I just want oral confirmation. What's your name? What's your matrix number?
Me?
Afika, Atira.
Afika Atira, metric number 1818236.
Okay, where's Hidayah? Is she back? No. Okay, any questions? Anggu or Geleng?
I think no questions, Doctor.
Apa nama penuh Hidayah? Apa nama penuh Hidayah? Hanis, nama penuh Hidayah?
Nur Hidayah Akmal.
NUR ke NOOR?
NUR.
Dua perkataan satu.
Satu.
Akmal, AKMAR.
AKMA. Nur Hidayah Akmal.
Binti,
Binti
Nama dia Nur Hidayah binti Akmal.
Binti Akmal.
Okay.
Okay.
Doktor,
I'm sorry.
Doktor, nama dia Nur Hidayah binti Ikemah.
Takkanlah colleagues pun tak tahu nama Nama dia apa sebenarnya? Nur
Nur
Hidayah
Hidayah
binti
binti Ikemah.
Ikma, IKMA. Ke Ikmal?
Yes, IKMA.
Okay. No questions and next presenter. Siapa presenter kedua?
Okay.
Siapa presenter kedua?
Me, Doktor. Abdul Lagi.
Okay. Kalau nak off camera, boleh off camera sekarang. Kalau Hidayah tiba-tiba muncul, suruh dia message saya. Kalau nak off camera dia.
So everyone can see the presentation slides.
Yes.
Okay, let's proceed to the second presentation. So I'll be presenting about measles, mumps, and rubella, these three viruses. So the outline for this seminar, first we will cover the MMR vaccine, and then for each of these viruses, measles, mumps, and rubella, we will cover the etiology and pathophysiology, the epidemiology, the global and in Malaysia, the clinical manifestation, complications, differential diagnosis, investigations, and also managements, and lastly, the prevention. So, MMR vaccine. So it is a vaccine, 3-in-1 vaccine, where the antigens from the viruses are put inside the bottle and then administered to the children as a single shot. So these viruses had been modified to become weak. So the purpose of these viruses is to elicit the body defense system to produce antibodies against the viruses. So these antibodies are used to fight off the condition if they encounter the virus in the future. So when will the vaccine will be administered? Usually it is given at 1 year of age, and a second booster dose is given at standard 1 or 6 to 7 years of age. Where will be the vaccine will be given? It is given as single injection to arm in older children and thigh in infants. So what are the importance of these vaccines? So these viruses are common cause of childhood illness. And since the introduction of this MMR vaccine, there has been decline of these cases. So to maintain the decline, we need to administer this vaccine. So the first virus is the measles. So the name is measles morbillivirus. It is a single-stranded RNA virus. The genus is morbillivirus, and the family is the Paramyxoviridae. So there are two membrane envelope proteins that are important in pathogenesis. First is the F protein. The second one is the H protein. So F protein is for the fusion of the virus, while the H protein is for the adsorption of virus to cells. So this virus has only one antigenic type or serology. So if previously infected, there'll be lifelong immunity. So humans are the only natural host, and this virus may present in the respiratory secretions, blood and urine of the infected individuals. So the mode of transmission for this virus is droplets or airborne route. So the pathophysiology of this virus. So all of these three viruses, MMR, measles, mumps, and rubella, they will infect through the respiratory tract. So when the infection is transmitted via the respiratory droplets, it will infect and replicate inside the tracheal and bronchial epithelial cells. After 2 to 4 days, it will infect local lymphatic tissues, which is the primary viremia, and then it will disseminate to the various organs prior to the appearance of rash, which indicates the secondary viremia. So this infection will cause generalized immunosuppression, which will be decrease in delayed type hypersensitivity, interleukin 12 production, and antigen-specific lymphoproliferative responses. So this immunosuppression may predispose individuals to secondary opportunistic infections, particularly bronchopneumonia, a major cause of measles-related mortality among younger children. So the epidemiology of this virus, it is endemic in regions of the world without the measles vaccination, and it is responsible for about 1 million of deaths annually. So globally, between 2016 and 2017, the number of cases has increased by 31% based on WHO statistics. In Malaysia, the Ministry of Health report that the cases of measles in Malaysia increased from 195 to 1934 in 2013 to 2018, which is almost 900% over a period of 5 years. So the number of cases, measles cases among unimmunized persons increased from 125 to 1467 in 2013 to 2018. So the incidence rate from 2016 to 2018 in Malaysia ranged from 50 to 60 per 1 million population. Meanwhile, there has been a decline in the number of measles cases recently from 2018 to 2019, which is from 1958 to 1077 cases in Malaysia. Moving on to clinical manifestation. So basically there are 4 phases: incubation, prodromal, exanthematous, and also recovery. But there are only 2 phases that is distinct, which is prodromal phase or catarrhal phase, and also exanthematous phase or rash phase. So the prodromal phase is infectious, while the rash phase is non-infectious. So the incubation period for the virus is 8 to 14 days, and the manifestation of prodromal phase. So prodromal means that it is early signs of the infection of the virus. Sorry, wait. Okay, sorry for the technical issues. So the manifestation of the prodromal phase, the 3-day phase, are the high fever, 3 Cs, the cough, coryza, and conjunctivitis. Coryza is acute inflammation of the mucous membrane of the nose. And conjunctivitis, we can see the Stimson line, which is the transverse line of inflammation along the eyelid margin. And there's also copic spots, which we can also say it is an enanthum. So there is enanthum, there is exanthum. So enanthum is rash inside the body, while exanthum is rash outside the body. So enanthum, which can be characterized by gray, white, sand grain sized dots on the buccal mucosa, opposite to the lower molars, that may last to 20 to 24 hours. So these are copic spots for measles. So the other phase, which is exanthematous phase, the rash phase. So we can see discrete erythematous maculopapular rash, which may appear on day 3 or 4 after the onset of the fever. So the distribution of the rash, it will start on the nape of the neck, and then it will spread upwards to involve the face, which will involve the behind the ears and the foreheads, and then it will spread downwards, which will involve trunk, limbs, and also soles and palms. So the rash have tendency to become confluent and blotchy, and eruption will begins to fade in second week, which may show this the rash will dischromate and pigmented. So the complications of this.
Okay, Hakim, stop.
Yes.
Turn back two slides. Stop, turn back two slides. The complex.
Yes.
The complex is quite hard to see because it's very early on. So you see it like roughly between the first 2 or 3 days. After that, it disappears. So don't base, I mean, if you catch it, if you see it in time, good. If you don't see it, doesn't mean it's not measles. All of the titles for this morning is all basically fever and rash. So it's important for you to remember the distribution and also the progression of the rash. So the next slide, I think. Slide yang kedua, yang lepas tu. So measles, you have to remember head all the way down. So from the head, it goes down to the body. And then after that, it's what we call, after it fades, you get post-measles pigmentation. So basically, the skin will become, where the rash was, will become darker for a while. Okay, so you can see that the place where the rash was will be kind of discolored, basically. But after that, we'll go back to normal. Okay? Yeah, continue. Hidayah hasn't popped out, right?
No, I called her already, but she didn't answer.
Okay.
Okay, let's proceed. The complication of measles, it is caused by the extension of the inflammation due to the virus infection, and also the secondary infection which may occur that will cause tissue damage, and also the aggravation of existing malnutrition. So there are many systems that may be affected by this virus. The head, respiratory, cardiovascular, GIT, pregnancy, eyes, and also hematological. So the differential diagnosis. So usually we diagnose measles clinically, which we look for the fever, rash, and 3C, cough, coryza, and conjunctivitis. So for the rash, we need to look for the distribution and the development of the rash. And the complete spots are pathognomic, which is characteristic for measles, but they are not always present at the time the rash is most pronounced. So the diagnosis can be confirmed by the antibody titer, increase in antibody titer. And it is important to differentiate the rash between other diseases like in rubella, roseola, enteroviral or adenoviral infection, infectious mononucleosis, toxoplasmosis, meningococci, scarlet fever, rickettsial disease, Kawasaki disease, serum sickness, and drug rash. So we need to know the characteristic for measles rash, which have been explained before. So the investigation for the disease. So as I said before, the diagnosis of measles is usually from clinical diagnosis, but we can use PCR and serologic tests to confirm the clinical diagnosis. So the routine lab findings are non-specific and do not aid in diagnosis, but we can do. And the findings that we can find in FVC, for example, FVC, we can see leukopenia, which is characteristic for measles, and also in CSF, cerebrospinal fluid, in patient with acute encephalitis due to measles infection. There will be increased protein and lymphocytic phagocytosis, and also normal glucose. So the management for the patient with measles infection. So we need to isolate the patient and may require hospitalization. The management is usually symptomatic and no antiviral therapy. So symptomatic management, we can maintain the fluid intake and nutritional state, and also antipyretics to relieve the fever. But in immunocompromised patient, we should give antiviral such as ribavirin. In developing country, we may give vitamin A, which may modulate immune response. And patient that present with secondary bacterial infection, we can administer antibiotics. For example, in patient with otitis media as a complication of the infection. So prevention for the measles infection. So we usually give vaccine to immunize the population. So in Sabah and Sarawak, we give measles vaccine at 6 months, and at 12 months in Peninsula, we give MMR vaccine. We can also give to susceptible contacts within 3 days of exposure. We give the vaccine, but the vaccine is not given during birth because of the maternal antibody, which can reduce the immunogenicity of the vaccine. So the second virus is mumps. So it is a single-stranded RNA virus. Genus Rubula virinae, and family is the Paramyxoviridae. So it is surrounded by a glycoprotein envelope. It has 2 glycoproteins on the surface of the RNA viral envelope. One is the H protein and the other one is F protein. So the H protein mediates neuraminidase and hemagglutination activity, while the F protein is for fusion. So the pathophysiology of mumps, so similar like the measles, it will enter through the respiratory system, through respiratory tract, and then it will replicate locally, and then there will be primary viremia, which it will spread to the local sites, and then it will disseminate to the target tissues, such as the salivary glands and also extrasalivary location. For example, salivary glands, parotid glands, and the extrasalivary locations is central nervous system. And then there will be secondary phase of viremia, which may occur before the immune response, maybe due to the replication of the virus at the target organs. So the tissue will respond with cell necrosis and inflammation with mononuclear cell infiltration. This will result in edema and desquamation of necrotic epithelial cells lining the ducts, So we can see the salivary glands enlargement of the salivary glands. So we move on to the epidemiology. It has a worldwide distribution and particularly prevalent in crowd urban community. So the incidence of mumps has declined dramatically because of the MMR vaccine, but there has been a rise in non-immunized child and unvaccinated young adults. So the disease is usually a disease of childhood or school-age children, which makes up to 90% of the population, the case. I'm sorry. Okay. Sorry. There's technical. Okay. So this disease is rare in early infancy because of the maternal antibody itself, which may protect the baby from the infection of the mumps virus. So the clinical manifestation for mumps Okay, so the incubation period of this virus is 14 to 21 days. The period of the infectivity of this virus is usually 7 days. And it can be divided into 2 to 3 days before the onset of the parotitis, the enlargement of the parotid glands, and also 3 days afterward, the onset of parotitis. So there are prodromal symptoms, which are the fever, headache, earache, malaise, anorexia, myalgia, swelling and pain over the parotid gland, and also trismus, which is pain on eating and drinking. So the signs of the mumps infection, we can see first, we can see parotitis, the enlargement of the parotid glands. So initially there will be unilateral enlargement, and then there will be bilateral enlargement, which occur 1 to 5 days later. So we can feel the skin over the parotid glands, which is edematous, red, warm, and tender, which are the cardinal signs of the inflammation. The Stensen's duct and the Wharton's duct may be erythematous and pouting. And usually the parotitis will gradually settle over 3 to 7 days. And other signs, we can see submandibular and sublingual infection, but it is less frequent. The complication of mumps, there are several, but the most frequent complication is meningoencephalitis, the neurological complication. So in the cerebrospinal fluid, we can see pleocytosis, which is increase in lymphocytes in the cerebrospinal fluid. So the cause may be because of the meningeal irritation and also increase in intracranial pressure. Other complications may include transient hearing loss for neurological, in cardiovascular, myocarditis, GIT, hepatitis, and pancreatitis. But pancreatitis is rare in childhood. And other in reproductive and others, orchitis, epididymitis, ophthalitis, arthritis, and mastitis. So differential diagnosis, to diagnose these mumps. So usually it is clinically diagnosed, but we need to consider other cause of this enlargement of the parotid glands. So there are several other causes like viral, bacterial, and sialectasis, cystic dilation of the ducts of salivary glands, mastoiditis, orchitis, epididymitis, and also drug reaction, which may include thiazide diuretics. So investigation for mumps infection. So I have said before, it is usually clinically diagnosed, but we can isolate the virus from urine, saliva, throat swab, or the cerebrospinal fluid in mumps meningitis. And we can also confirm the diagnosis from the raise of the serum antibody titer. So the definitive diagnosis can be made from the viral isolation in serology and serology of the viral antigen. So management of this patient, usually it is symptomatic management. We can give analgesia, paracetamol. We can provide adequate nutrition and mouth hygiene. We may guide bed rest, but there are no antiviral therapy for the mumps infection. So prevention for mumps infection. So usually we vaccinate the susceptible children, adolescents, and adults against the mumps. But if there is contraindication, we don't give vaccination. So the mumps vaccine is important for children approaching puberty and for adolescents and adults who have not had mumps. So in Malaysia, we give the MMR vaccine at 12 months old. Okay. So moving on to rubella. So rubella virus, also known as germal measles or 3-day measles. So it is a single-stranded RNA virus, same like the other two. So the genus is rubivirus, family Togaviridae. So it has only single serotype. So if previously infected, there will be lifelong immunity. So similar like the other two, it is transmitted via respiratory droplet. And but there is extra one, which is transplacental transmission. So humans are the only known host. So pathophysiology, I'll be covering about the postnatal rubella and also the congenital rubella. So for postnatal rubella, the entry of the rubella virus by the respiratory epithelium of the nasopharynx. After the entry, it will attach and invade the respiratory epithelium, and then there will be primary viremia to regional and distant lymphatics and replicates in the reticuloendothelial system. After that, there will be secondary viremia spread to the other organs that will occur 6 to 20 days after the infection. So for congenital rubella, the infection will be transmitted transplacentally during the maternal viremic phase. So when the mother is infected, during that time there will be transplacental transmission. So there'll be fatal damage, but the mechanism of which the rubella virus caused fatal damage are poorly understood. But there has been two theory. The first one is the direct viral damage of infected cells. So the cells that are infected by the rubella virus will have reduced mitotic activity. So this may be the result of the chromosomal breakage or due to the production of protein that inhibits mitosis. And the other theory is that the fetal defects is secondary to vasculitis, resulting in tissue necrosis without inflammation. So the epidemiology, in unvaccinated population, rubella usually occurs in spring with epidemics occurring in cycles of every 6 to 9 years. Approximately, there is 25 to 50% cases are subclinical. The outbreaks occasionally occur in non-vaccinated groups from internationally imported case. The transplacental antibody is protective during first 6 months of life. So if the mother is protected against the rubella, so the child may be protected too. So the incidence in Malaysia, the incidence of rubella decreased from 7 to 5.6 per 1 million population in Malaysia from 2014 to 2018 based on WHO statistics. The clinical manifestation of rubella, so we need to know the incubation period is 14 to 21 days. The infectious phase is from 1 week before and after the rash. So the symptoms for rubella, first the symptoms will be low-grade fever, malaise, and headache, and there's also conjunctivitis. And the most important one is the skin rash. So we need to know the development of the rash. First, it will start from face, and then it will spread rapidly to the whole body. So the rash may be discrete erythematous macules. And then at day 3, the rash will fade on the trunk only. And the next day, the rash will disappear completely, rapidly. So the signs. So we need to look for the signs. So for the first one, we can see four Kimmer spots. It is only suggestive but not diagnostic. So Fortmer spots is a petechial lesion on the soft palate. You can see at this picture, And then there'll be characteristic lymphadenopathy. So there'll be lymph node enlargement at the suboccipital, post-auricular, and post-cervical groups. And then there'll be maculopapular rash and also splenomegaly. So for complication, other than the congenital rubella syndrome, other complications are rare. So patient with rubella encephalitis, will rarely have so death rarely occur with rubella encephalitis. So there are many complications such as the encephalitis, myocarditis, arthritis, thrombocytopenic purpura, and also hemorrhagic manifestation. So complication in congenital rubella syndrome. So it occurs when non-immune pregnant woman is infected during first trimester, usually the first month of pregnancy. So there'll be transplacental transfer of the virus during viremia phase. The virus will reach the fetus via emboli of infection endothelium. So in some cases, there'll be rapid death, spontaneous abortion, and also persistent infection. Significant malformation occur as a result of fetal and maternal viremia. So the fetal infection depends on the stage of gestation. So there are many complications of the congenital rubella syndrome towards the fetus. For the general one, we can see growth retardation, learning disabilities, and spontaneous abortion. For the head, we can see microcephaly, mental retardation, and rubella retinopathy, for example, cataract and glaucoma, and also sensory neural deafness. And lastly, for the cardiovascular complication, we can see PDA and VSD.
Most of the complications is worse if you if the infection is you get it earlier in the pregnancy, right? So usually the full-blown congenital rubella syndrome is when the mother gets it during the first trimester. The later you get it, the less it affects the baby, which makes sense lah. Because if you think about it, you get it during the first trimester. That is when all your organs start developing, isn't it? Right? If you get it during the last trimester, most of your organs will developed already. Yeah, continue.
So differential diagnosis for rubella. So we need to know, so the diagnosis is usually clinical, but we need to differentiate the rash from other diseases like the measles, roseola, and other diseases that may present with fever and rash. So the characteristic for the rash for rubella, it will start from the face and then spread to the whole body. And at day 3, it will fade on trunk, and then the next day it will fade completely. So investigation for rubella. So we can confirm the clinical diagnosis from by looking for the antibody titer. There'll be four-fold rise in IgG. We can also do tissue culture from nasopharyngeal secretion or serology tests like hemagglutination test or ELISA. We can also do viral isolation or PCR in throat swab or synovial fluid. So in congenital rubella, we can look for IgM in fetal blood and also virus isolation in amniotic fluid. Management for patient with rubella. So it is self-limited, usually no specific therapy for rubella. But we can give symptomatic treatment like maintaining adequate hydration and also antipyretics. So prevention for rubella, we need to give vaccine like attenuated rubella vaccine. And to prevent the congenital rubella, we need to control postnatal rubella by vaccinating 12-month-old baby and 6-year-old school entry children. We can also vaccine the female of childbearing age. So we can include it in screening in pregnancy. And also people with exposure risk like healthcare workers and teachers. So in Malaysia, we usually give the vaccine at 12 months old, which is the MMR vaccine. So I think that's all. Any questions? So these are my references.
No question.
I have question. As in the rubella, you said it was known as the 3-day measles. Is there any important there?
Oh yes. So the 3-day measles. So we can see that the manifestation of this skin rash, which will last to 3 days. So that what means by the 3-day measles.
On the rubella.
Yes, rubella. Yes.
Okay.
It's not important to say because measles is called measles, right? Rubella is called German measles. Okay, but they are two totally different things, right? Now, if measles, the rash lasts much longer. The symptoms last much longer. Usually about 10 to 14 days. So in German measles, which is rubella, they just kind of name it 3-day measles because the rash lasts for 3 days. It's kind of a way for the olden days to differentiate from measles, even though they are two totally different things. Right? It's just a name. Right? So you learn rubella as rubella, you learn measles as measles first. Because if you're gonna put on German measles, tack on German measles onto rubella so early, what you're gonna do is that you're gonna confuse your brain when your brain is trying to memorize stuff, right? So learn measles as measles, learn rubella as rubella. Okay, then only later on you just, by the way, German measles is also rubella. This is more towards to the way you study later on and how you remember things later on, because I think Hanis, I asked you to keep aside the slide that I asked you to delete, right? Later on, after the whole thing is finished, then Hanis, you put on that slide. Now I'll show you guys why the slide that I asked Hanis to delete is not a good slide to have in terms of being a medical student and trying to remember facts. Okay, we'll just continue. Any other questions, Mark?
Another question. From those three, who are the most common one?
Most common one between these three.
Who asked the question? Oh yeah, housekeeping. Before you guys ask a question, introduce yourselves. Say who is talking. Okay.
I'm sorry. My name is Mama Ikwan. I would like to ask from these three virus, who are the most common one in our country?
I think based on the WHO statistic, I will share the statistic later. I think the most common is measles, because the statistic is more focused on measles. While I look for mumps and rubella, there is some statistic in mumps, but there's no statistic for rubella. I'll be sharing the WHO statistic in the WhatsApp group later. But I think the most common is measles.
You do hear about measles more often than mumps and rubella. But okay, continue.
Okay, thank you.
So any other questions? No? Okay. I think that's all. Thank you.
Yeah, Assalamualaikum warahmatullahi wabarakatuh, and good morning to all of you. My name is Amina Abdulrahman. All right. I will be continuing this seminar on virology with two other differentials of fever and rash, which are varicella and herpes zoster. My presentation will be according to the usual flow, beginning with the introduction and epidemiology, followed by all the subtopics, and ending with the complications and the prognosis. Can you guys see both my slides and the pointer?
Yes.
Yes. Okay, thank you. Right, so let's begin. So varicella and herpes zoster are two distinct different diseases caused by the same virus. When a host is infected for the first time with the virus, the primary infection will manifest as varicella, which is commonly called chickenpox. It's a common, highly contagious disease, which usually manifests as a mild illness of childhood. It has a characteristic exanthem, which is a vesiculopustular rash. And after recovery from this infection, usually the host will have a lifelong immunity against symptomatic reinfection. But however, it also causes an establishment of a latent infection, which will lead us to the next disease, which is zoster. So the reactivation of the latent infection of endogenous varicella zoster virus, endogenous from the previous exposure of varicella. So this reactivation will manifest as shingles, which is quite a common opportunistic infection in older adults. So it also causes a vesicular type of rash, and however, in shingles, the rash is painful and localized to a dermatome, whereas in varicella, it's widespread. In shingles, it's just in one area. Moving on to the epidemiology. So in both chickenpox and shingles have a worldwide distribution. In countries like the US, after the introduction of the varicella vaccine in the 1990s, because of its introduction to the national immunization program, there has been a great decline in cases in all age groups and a shifting of the peak occurrence age to an older, still children, but it moved to 10 to 14 years. As for Malaysia, I couldn't find an exact incidence because though varicella is highly contagious, it's usually mild and self-limiting in children, and um, it's not a notifiable illness, and it's not a major public health concern. So yeah, the exact incidence is unknown, but I did read in the newspaper that there were several outbreaks involving mainly institutions like daycare centers and kindergartens in the past few years. Okay, as for shingles, the incidence rate is similar in Malaysia as to most other countries. So it ranges between 3 and 5 per 1,000 person years. As with other opportunistic infections, the incidence increases with age and peaks at around 70 years. So it's quite uncommon in children, but yeah, I'll be presenting about it too. So for an individual who has had a history of varicella, the lifetime risk of getting shingles is about 20 to 30%. Okay, so what causes both of these diseases? The virus is conveniently named the varicella zoster virus. It's a member of the herpes viridae family. It's also known as the human herpes virus type 3. It's an enveloped icosahedral double-stranded DNA virus, and humans are the only natural host for this virus. The incubation period is usually around 14 to 16 days. Right, so since humans are the only host, the transmission is person to person. It can occur, it occurs because of contact with the fluid from the skin lesions, either because of direct contact or because of airborne spread. In the case of varicella, it can also be transmitted through oropharyngeal secretions, like when the patient coughs or sneezes, but not for herpes zoster, okay? This is about the period of infectivity, just like in mumps just now, 1 to 2 days before the rash and 3 to 7 days after the onset of rash. Right. Okay, let's move on to the pathogenesis. So the virus enters the body through the conjunctiva or the upper respiratory tract, and then it replicates in the respiratory tract mucosa and in the local lymphoid tissue, like in the tonsils, and eventually it reaches the bloodstream, causing brief period of subclinical viremia around the 4th to 6th day, and this viremia disseminates the virus to the regional lymph nodes and to the liver and the spleen and the other organs, and where it replicates in these organs. After this, there is a phase of secondary viremia, which is clinically apparent because in this phase, the virus succeeds in reaching the target organ, which is the skin cells, and causes the vesicular pustular rash over there. Right, so from here, that is from the skin lesions, the virus travels to, okay, this is clearer. Right, so from the skin lesion, the virus travels in an retrograde manner along a sensory nerve and establishes a latent infection in the sensory ganglion. And this leads us to the pathogenesis of the next disease, of shingles. So in shingles, there is a host with previous varicella infection, so they have a latent infection in the sensory ganglion, and then the host's immune system gets weakened because of old age or drugs, whatever condition, and the virus reactivates and starts replicating again in the dorsal root ganglion, causing inflammation and pain along in the area that ganglion supplies, and then it replicates and the virus travels back anterogradely along the nerve back to the skin and causes a rash, a vesicular rash in the corresponding dermatome. Okay, let's talk a bit more about the clinical manifestations. So I'll be presenting about the typical presentation of varicella in unvaccinated individuals. Okay. So in both varicella and zoster, there is a phase of a pre-eruption phase where there are prodromal symptoms like non-specific systemic symptoms because of the viremia, and the severity of the symptoms varies, but it's usually more severe in adults and older children. So the prodromal symptoms include fever. In varicella include fever, malaise, anorexia, headache, mild abdominal pain, lymphadenopathy, etc. And all these symptoms usually supposedly should resolve within 2 to 4 days of the onset of the rash. Okay, let's talk a bit more about the rash because this part is important. So the rash in varicella, the lesions first occur in the trunk and then they go on to the face and the scalp, and it can also progress to the peripheries. However, the area of highest distribution is in the trunk. So in varicella, the distribution pattern is central. Okay, the number of lesions varies depending on the severity of the disease. So it can be anywhere from 150 to 1,000 lesions. Usually it's 300. Okay, so new lesions keep coming up for about a week or less, and each of these new lesions needs to go through a series of characteristic stages. So initially it begins as small macules, which are like patches of discoloration of the skin, and then it progresses to the papular stage, which are small red bumps, sometimes itchy, and then it becomes vesicles, as you can see in the picture here. It's like thin-walled and filled with a clear fluid. It's going to be very itchy. After this, all these stages happen quickly, like within a day, and then the vesicle progresses to become a pustule, and after that, in a few days, the pustule will dry off and a hard crust will form over the lesion, and the lesion will turn into a scab, like a wound scab, and it will fall off in a couple of weeks. Right, so like I said, new lesions keep coming for about a week. So in varicella, around like the third, fourth day, you should be able to see different lesions, lesions in various stages. So for example, you can see pustule here. Probably this is a blister. That might be a scar, a crusted. Yeah, you get the idea. So this presence of various stages of lesions in simultaneously is characteristic of varicella. Okay. Let's move on to the shingles. Okay. Right. So shingles in okay, so as I mentioned, shingles is quite uncommon in children. So this presentation is about the typical presentation of zoster in adults and immunocompromised children. In the rare case that shingles does occur in immunocompetent children, the disease will be much more mild, and like the neuritis, the pain will be minimal, and overall the disease is much more mild. Okay, so in adults, there'll be a prodromal phase like we had in varicella with non-specific systemic symptoms, and which will happen like 2 to 3 days before the eruption phase. But what's characteristic in zoster is that you have a burning pain and tenderness along a specific area, which is along the dermatome of the ganglion where the neuritis occurred. This is called preherpetic neuralgia, and it's actually the most common presentation of zoster patients. They go to the hospital because of the pain, and the next common presentation is because of the itching. So like in varicella, after the prodromal phase, in the eruption phase, there'll be macules and papules, which will then vesiculate, and then it will dry up and crust and heal. In zoster, right, so the lesions are in a dermatomal pattern, and this is because of the infection of that sensory ganglion, right? So it's either the right or the left sensory ganglion, which is infected. So depending on which, the lesions will be in a unilateral distribution and it won't cross the midline. Okay. Yeah, and it can, okay, so usually it's in the dorsal root ganglion, but it can also affect the ganglion of the cranial nerves, usually the trigeminal nerve, in which case it will cause distribution of this pattern. This is called herpes zoster ophthalmicus because the ophthalmic division of the trigeminal nerve is involved in this case. The most common area of lesions in zoster is the thoracic region, followed by the lumbar region. Okay, right. So remember how I said that the rash is the most important part because the diagnosis is for both varicella and zoster is a clinical diagnosis based on the distinctive characteristics of the rash. So, however, there are other diseases which you can consider when a patient presents with vesicular rash and fever. For example, eczema herpeticum, which is caused by the herpes simplex virus, herpes virus type 1 and type 2. This also causes a localized vesicular eruption that sometimes appears to be in a dermatomal pattern. So it might get confused with herpes zoster. Another differential would be impetigo, which is a bacterial skin infection. In impetigo, there are fewer lesions and the distribution is different. It's more in a perioral area and the peripheral areas, while in varicella, it's more in the central areas, okay? Initially, you might confuse it with chickenpox, but later on, the cresting in impetigo is honey-colored, and I think it's unique to that disease. Okay. So, yeah, the diagnosis of both varicella and zoster is a clinical diagnosis, so lab test confirmation is usually unnecessary. But in the event that there is an atypical presentation with, say, very few lesions, or if the patient is a high-risk patient with complications and you need to confirm the diagnosis, then the current diagnostic method of choice is the polymerase chain reaction. It's very sensitive and specific for the virus, but it might take a long time depending on the availability of it at the institution. Another tool would be the direct fluorescent antibody assay, where you look for the varicella specific antigen. It's less sensitive than the PCR, but it can be quicker if it's available. Zinc smear can also be used, but nowadays it's less commonly used, and also it's not strictly diagnostic because it can help differentiate between herpes viruses and non-herpes viruses, but you wouldn't be able to tell if it's varicella zoster or herpes simplex. So Zinc smear and viral culture is less commonly used nowadays, though viral culture is the gold standard. But like explained before, yeah, it has its disadvantages. All right, let's move on to the management. Right. So both varicella and herpes zoster in immunocompetent patients is usually a mild self-limited illness. So symptomatic therapy is enough. For example, for the fever, you can give antipyretics like acetaminophen or any other analgesics for the pain in zoster. However, these drugs are not advised, aspirin and brufen. Aspirin especially because both of these drugs can increase the risk of complications. Aspirin and any other salicylate containing drug can predispose to a complication called Rayleigh syndrome. For the pruritics, you can use antipruritics like calamine lotion or any other skin lotion or herbal remedies or cool and wet compresses. And also because of the pruritus, the patient is advised to maintain hygiene by keeping the fingernails short so that to reduce scratching of the blisters, because the blisters can be itchy So, but if you scratch it, it can cause secondary bacterial infection, which is one of the most common complications. Right. So usually symptomatic therapy is enough, but depending on, for example, host factors, if the patient is older or immunocompromised or has comorbidities, for example, or if the patient is a high-risk patient with high risk for severe disease and complications, then antiviral therapy may be considered. So for pediatric cases, the acyclovir is the only antiviral drug available in liquid formation for the treatment of varicella. In adults, while acyclovir and famciclovir is preferred over acyclovir, the same group of drugs are also given for zoster patients. Okay, again, the antiviral therapy is not always needed, depending on the severity of the disease. Okay. Right, so I included the prevention in here. Both varicella and zoster have safe and effective vaccines available in Malaysia. Varicella vaccines, there are various types available. For the shingles vaccine, there's only one, which is Zostavax, which is indicated in individuals above 50 to 60 years old and in high-risk populations. All the vaccines are administered as a subcutaneous injection and usually requires only a single or double dose. Okay, so for post-exposure prophylaxis, specifically in immunocompromised children, pregnant women, and newborns, or in a susceptible high-risk patient who has had a close contact with a patient with herpes zoster, then high-titer anti-varicella zoster virus immune globulin is used. The available product is Varizig. I think the same thing is used in Malaysia too. Right. So if other groups of population apart from like these people, like if immunocompetent children are exposed to varicella, then you can use the vaccine straight away for post-exposure prophylaxis. So let's move on to the last part, which is the complications and the prognosis. The most common complication in both varicella and zoster is the secondary bacterial infections of the skin. Usually it is mild, but in immunocompromised patients, these can lead to severe complications of the bacterial infection, like toxic shock syndrome or necrotizing fasciitis. Yeah, so also in immunocompromised patients where the host immune response is not enough to stop the viral replication, the virus can disseminate to the organs and cause inflammation there. So complications include pneumonitis, encephalitis, hepatitis, disseminated intravascular coagulopathy. Yeah, but again, all of these complications are rare, except for secondary bacterial infections of the skin, and in zoster, post-herpetic neuralgia. This is a very common complication in adults and immunocompromised children. It's when the neuralgia due to the herpes virus continues even after the resolution of the rash, sometimes up to 1 year. Okay, now the final part. Right, so varicella and herpes zoster in immunocompetent children is self-limited and a mild disease. So except for secondary bacterial infections, serious complications are rare. So it has an excellent prognosis. However, if in immunocompromised children, there can be a severe presentation of the disease with severe complications and sometimes mortalities. But again, this is rare. All right. These are my references. Any questions? Thank you. Okay. That's it from me. Is there any
Any
question?
questions on?
If not,
And then
Shall I? Okay.
So the important thing about chickenpox is to remember the progression, how it looks like. So you get little pustules, and then they burst, vesicles, and then they burst, and then they get over, right? And then you get coughs of it. Also, be very aware because of cultural practices. So a lot of times you end up with children who get admitted because of secondary infection, because a lot of if you follow what the old people do, some of them they spread some sort of kunyit concoction on the chicken pox, right? And then those chicken pox lesions get infected. Most times they don't need admission unless there's complication. Chickenpox vaccination is not part of the government vaccination schedule, but it's a good idea to get vaccinated because of potential complications. It's not just the fact that a lot of people think chickenpox is minor, but once a child gets an infection, like secondary pneumonitis, or they get a post varicella cerebrolitis, the complications itself is bad lah. So if you can afford it, it's better to get immunized. The shingles immunization is only for adults above the age of 50 who has a risk of it. I think there's an issue of whether it's halal or not. You guys read into it and decide for yourself, because I'm not in the place to mention to talk about it. Next presentation.
Okay. Can you see my slides?
Yes, we can.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Afiq bin Muhammad Nasir, metric number 1810533, and today I'll be presenting about hand, foot, mouth disease. Okay, so here are the table of contents of my presentation today. So firstly, I'll be giving a brief introduction of the disease itself, followed by the etiology or the virology of the hand, foot, mouth disease, and then followed by epidemiology, pathogenesis, clinical features of hand, foot, mouth disease, which include the signs and symptoms, and also a variant of the hand, foot, mouth disease, which is a Coxsackie virus A6HFMD, and then the differential diagnosis of hand, foot, mouth disease, followed by its complications, and also on how to diagnose hand, foot, mouth disease, and lastly, the management and prevention of hand, foot, mouth disease. So let's begin. Okay, hand, foot, mouth disease is defined as a clinical syndrome which is characterized by the oral enanthum, which is also known as the oral ulcerations, and the macular or maculopapular or the vesicular rash of hands and feet, as the name suggests, from the disease, hand, foot, mouth disease. Okay, hand, foot, mouth disease is actually due to a systemic infections from the human enterovirus A species. To get hand, foot, mouth disease, only enterovirus which can infect humans can cause the disease, such as the Coxsackie virus group from group A and B, echoviruses, and enterovirus number 68, 69, 70, and 71. There are two common viruses that could cause hand, foot, mouth disease, which are Coxsackie virus A16 and enterovirus A71. Enterovirus A71 is actually a hand, foot, mouth disease, which is caused by infection of enterovirus A71 is actually a public health concern as it comes with complications, particularly neurological and cardiopulmonary complications that I will discuss later on. And based on this table below, here is the list of organisms, the causative agents of hand, foot, and mouth disease. And in the bold, the organisms that are in bold represents the causative agent, which is common in the Asia Pacific region, which are the Coxsackie virus A16 and enterovirus A71. Next, we move on to the epidemiology of hand, foot, and mouth disease. Actually, this kind of disease can happen worldwide, and it actually can cause outbreaks in crowded places, such as in daycare centers, which is the most common place to get hand, foot, and mouth disease, and also schools, hospital wards, and military installations. This disease can happen in temperate temperatures, such as in our country, and also in the western part of the world. It usually happens in there is a seasonal pattern of the disease, which mainly occur during the summer and also in autumn. Summer and spring, which is the temperate temperatures. And actually, there is an epidemic of hand, foot, mouth disease, which happens in Sarawak, Malaysia, in 1997. And this kind of disease usually involves in the pediatric group, particularly in the infants and children, due to poor hygiene. And it is transmitted via fecal-oral route, i.e. from oral ingestion of fecal material which is infected from the disease, or also oral secretions of oral secretions such as from infected saliva, and also from the ingestion of vesicular fluid. And also the incubation period of hand, foot, mouth disease is usually 3 to 5 days. So how does this disease, what is the pathogenesis of this disease? So firstly, it begins with an oral ingestion of the infected fecal material, or the oral secretions, or the respiratory secretions, or the vesicular fluids. And then the enteroviruses will replicate in the submucosal lymphoid tissue of the small intestine of the patient, and then it will then spread to the regional lymph nodes and replicate. And the virus, they will then disseminate throughout the body, causing infection of reticuloendothelial tissues and multiple organs. This is a condition known as minor viremia. And then major viremia will happen when there is further replication at the disseminated sites. So from here, the sign of symptoms of hand, foot, mouth disease will occur. Next, we move on to the clinical features of HFMD. The symptoms of hand, foot, mouth disease is actually not diagnostic. So the patient could complain with fever due to the infection, and the patient itself, the children, will complain with mouth or throat pain. And in smaller, younger children who cannot talk yet, the guardian might complain of refusal to eat from the patient. And also, like other viral diseases that we mentioned from the previously from the other presenters, hand, foot, and mouth disease can also come with prodromal symptoms. Okay, prodromal is the sign and symptoms which shows before the diagnostic clinical features happen, such as in hand, foot, mouth, and mouth disease. Symptoms such as fever, fussiness. Fussiness is met by bad tantrums of the patient. Abdominal pain, emesis, and diarrhea will happen first before the diagnostic clinical features of HFMD, which are the oral anemptoms and the exanthems that will be discussed after this. Okay, during physical examination of the patient, there are two cardinal signs that we should look for in the patient. Firstly, the oral ananthem or the oral ulcerations. Okay, the oral ananthem in HFMD usually happens in 90% of the patients. It is actually mostly located at the tongue and buccal mucosa as shown in the picture here. Okay, firstly, the oral ananthems firstly will begin as macules, and then it will become vesicles, and around the vesicles there will be a halo of erythema as shown in the picture here. It is redness, and then it will form superficial ulcers, which is actually kind of indistinguishable to aphthous ulcers. Next, we have the next cardinal sign, which is the exanthem or the vesicular lesion. Okay, in HFMD, the exanthem we present is with macular or maculopapular, or even which is more common, the vesicular lesion, which is characterized with thin wall, contain clear or turbid or grayish fluid in the vesicles. These exanthems will be located at the sides of the fingers, at the instep of the feet, and also between the toes. This sign is more frequent in infants and young children. Bear in mind that the exanthems are not painful and non-pruritic. So these cardinal signs, that oral exanthem or oral ananthems and the exanthem, can exist alone to show that the patient has HFMD. So it doesn't mean that both the exanthems and the ananthem should present together to be diagnosed as HFMD. Then we have the variant of the hand-foot-mouth disease, which is the Coxsackie virus A6 HFMD, which is a more severe disease. It will present with a higher fever compared to the other serotypes of the causative agent. And then it is more wider in distribution, involves more of the extremities, and the lesion is concentrated in the area of active dermal eczema. So when there is patient comes with has a prior eczema, so the lesion of the disease will be at the extremities, will cause exaggeration of the dermal eczema, and there will be more skin involvement. So the lesion will be vesicular bullous, bullae, ulcerations, and eschar. The duration is a bit more longer, and there is palmar and plantar desquamation and nail dystrophy. So here is a picture of the Coxsackie virus A6 HFMD, which will show eczema of eczema coxsackium. It's actually a bit different compared to the regular HFMD, which shows a vesicular lesion. So here there's a bit rashes, redness here, which shows eczema. Then we have the differential diagnosis of HFMD. Some diseases might show similar signs and symptoms of HFMD. That includes aphthous ulcers, primary herpes simplex gingival stomatitis, and pruritic lesions such as from insect bites, varicella, and contact dermatitis. Okay, for aphthous ulcers, as you could see in the picture here, there is also mouth ulcerations here. So aphthous ulcers is actually in layman terms as mouth ulcers, or in Bahasa Melayu, ulceration, mulut ulcer. So here in aphthous ulcers, there is lesion at the between the lips here. Quite similar, if you look closely, it's actually quite similar to the oral ananthems of the HFMD. So aphthous ulcers is usually caused by minor injury, minor trauma of the oral cavity, such as from excessive aggressive toothbrushing or taking some certain types of food. And to differentiate aphthous ulcers don't actually come with fever and don't have extremity lesions such as in HFMD. Next, we have the primary herpes simplex gingival stomatitis. So in this disease, we could see here that the patient comes with, it is characterized with a gingival lesion. As you can see in this picture here, the left picture, it shows it is the gingiva of the patient is erythematous and red erythematous, and there is bleeding here. Oral gingival lesion doesn't happen in HFMD. And also in this disease, there is also oral enanthems. So what actually differentiates primary herpes simplex gingival stomatitis and HFMD are the seasonality of the disease, as HFMD usually comes in seasons, whereas this disease does not. And HFMD also have the peripheral lesions, extremity lesions, which is at the exanthems, which happen at the between the hands and the foot. Unlike for this disease, primary herpes simplex gingival stomatitis, it doesn't have extremity lesion. Next is the pruritic lesions. So the left picture here is the vesicles of the varicella. So this chickenpox, usually the rashes, the vesicles are quite diffuse. Unlike in HFMD, the exanthems only exist at the hands and the feet. So the vesicles are pruritic lesion. And next here we have the insect bites, which is localized and not diffuse. So the picture below here is the eczema, which is indicated as rash over here. Bear in mind that HFMD exanthems are non-pruritic and not painful. Moving on to the complications of hand-foot-mouth disease. So hand-foot-mouth disease rarely has complications except for enterovirus A71 HFMD. Okay, for a severe disease of hand-foot-mouth disease, patient might come with a decreased oral intake due to the disease. It causes dehydration, and the patient will need parenteral and fluid therapy. And also in enterovirus A71 HFMD, there will be rhomboencephalitis, which is encephalitis of the brainstem, acute fluid paralysis, aseptic meningitis, and myocarditis. Okay, so when there is, like I mentioned earlier, enterovirus A71 HFMD is a public health concern because it causes outbreaks and cause complications. There are 4 stages of complications of enterovirus A71 HFMD. Firstly, it will show as like any regular HFMD. There will be oral ulcers, the enanthems, the vesicular rash on the hands, feet, and knees. And then at stage 2, there will be show the complications. Firstly, we'll begin with the CNS involvement. Patient will come with aseptic meningitis, which will show as headache, myoclonic jerks, CSF pleocytosis, which is increase of the white blood cell count in the CSF. No altered, and in aseptic meningitis, there is no altered consciousness compared to encephalitis. Apart from aseptic meningitis, patient could also come with encephalitis, which will show with altered level of consciousness and CSF pleocytosis. Or the patient will come with poliomyelitis-like syndrome. And as the name suggests, poliomyelitis, the patient will come with acute limb weakness and decreased reflex and muscle strength. Or the patient can come also with encephalomyelitis, which shows both poliomyelitis-like syndrome and encephalitis. The third stage of enterovirus 71 HFMD is the cardiopulmonary failure, pulmonary edema, or hemorrhage, pulmonary hemorrhage. So there will be decreased ejection fraction of the left ventricle in echocardiogram. And in stage 4 is the convalescence period, which is the recovery from the cardiopulmonary complications. So how do we diagnose hand, foot, and mouth disease? Like the previous presentations, it is also diagnosed clinically based on the typical appearance and location of the oral enanthum and the exanthum. So usually investigation we don't confirm the diagnosis with the investigation. But however, in certain cases, we do polymerase chain reaction in cases with isolated exanthum, where the exanthum does not usually comes with at the hands and the feet, usually just localized at one place only. And we also do PCR when there is complications, such as in the enterovirus A71 HFMD. So the sample will be collected from the throat, stool, or at the vesicular fluid. Next is the management and prevention of HFMD. Hand, foot, and mouth disease is a self-limiting disease. So it will just go away for a few days. So to treat this, there will be only supportive treatment if the disease is not severe. So the supportive treatment, if there is for pain and fever from the disease, we'll just give ibuprofen, NSAIDs, and antipyretics such as ibuprofen and acetaminophen. And in this disease, it is adequate hydration and rest is crucial. However, there are certain conditions where the patient might need hospitalization. The indications are inability to maintain adequate hydration. So there will be need parenteral and fluid therapy, or even the patient develop neurological or cardiological complications, or there is persistent fever, hyperpyrexia, for more than 2 days, and also if the patient appears clinically ill or the toxic looking. I mentioned earlier that hand, foot, mouth disease can happen in outbreaks, not usually in sporadic cases. So in outbreaks, it usually involves the enterovirus A71. An outbreak is defined as the occurrence of 2 or more cases in the same locality. For example, the same locality is made for one place, such as in school areas, or the care center within the incubation period. The incubation period of HFMD is 3 to 5 days. The risk factors of an outbreak includes the host, which is the patient itself. Does the patient transmit the disease to the other people around him or her, or the environment itself, the temperature of the environment or the season, and also the organism itself, which is the enterovirus A71. Okay, based on the Malaysian guideline for hand, foot, and mouth disease, how do we manage this outbreak? Firstly, we exclude the patient from the institution, such as from the school or the care center, for at least 10 days, which is the incubation period. Double the incubation period. And then we must refer the case of hand, foot, mouth disease if there is complications, and collect swabs from the patients from oral ulcers and vascular lesions. If there are no longer vascular lesions or oral ulcers, collect stool sample, as the virus will remain even more longer in the GI of GIT of the patient. And teachers should be more alert for their children, with fever or with rash on palms and soles. So if there is any case happen before this, teacher should do a screening first, and then close the premise for 2 incubation period for disinfection procedures. Okay, lastly, on how to prevent hand, foot, and mouth disease. So in this, to prevent this disease, it is actually hygiene is the utmost importance. So parents and teachers alike should teach the children proper hand hygiene to avoid this disease. And the childcare settings should have strict hand hygiene protocol. And if the child appears febrile, exclude the child from coming to the childcare center. And in a hospital setting, for hospitalized HFMD patients, the patient should be isolated from other patients to avoid transmission of the disease to the other patients. So here are my references. So with that, we've concluded our virology seminar for today. So any questions?
Assalamualaikum. My name is Muhammad Ifaz Zaim. I want to ask regarding the stages for enterovirus 71 infection. Regarding that infection, is from stages to stages, is there any specific duration from stage 1 to progress to stage 2? Is there any specific duration for from the common symptoms to progress to CNS involvement?
I'm sorry for that because I didn't find more further about the duration of the stage itself, and because the complications, might happen. And
I guess stages they might not happen.
yes.
It's just how they name it. If the CNS involvement is stage 2. If it's just the basic one, then it's just stage 1. It's not as in stages as in it will definitely progress kind of thing. It's just that if it happens like this, then it's called stage 2. It's kind of like dengue fever lah. If it fulfills a certain criteria, then you call it dengue hemorrhagic fever. If it doesn't fulfill the criteria, then it's just basic dengue fever. Understand, no?
Understand. Yes. Any more questions?
No. Okay, Hanis, share that slide. Yeah, so you erase already.
Okay.
Okay, now I think because this slide, I think many batches of you have used the same slide, because let's be real, all of you just cut and paste. A lot of you guys will cut and paste from your seniors, right? And there's no shame in cutting and pasting. There's no shame in cutting and pasting if you know what you're presenting, right? So even you take your seniors presentation, you need to go through it, and whatever it is that doesn't make sense or doesn't make sense to you, or that you don't quite understand, take it out and replace it with something else. Now, I think this was taken from this website, right, maccomic.com. This is a very good example of what not to do if you want to study well. Okay, now, how many of you before this knew that measles is rubiola? Not many, right? You know measles as measles, right? Measles as teman campak. Most of us know rubella as rubella, right? Okay, Rosella infantum is a new thing that you guys just know now. Okay, fine. Now, the problem with this is that the illustrator is trying to show you the differences between these three conditions. Okay? But the problem is they put the three names that sound the most similar to each other. Rubeola, rubella, and roseola infantum. This is a recipe for disaster because your brain will link these three conditions together and mix everything up because they sound so similar. You get what I mean? It's kind of like if you have a friend named Ahmad Jamal. Change the other one. Make your friend look at this too long. Okay, if you have a friend named Ahmad Jamal and you have a friend named Ahmad Jamil, right? And Jamal has always been called Ahmad, right? Jamil has always been called Jamil, right? Ahmad is never called Jamal. You get what I mean? One bright day, I'm still having class today. One bright day, the teacher decided to call Jamal, who is usually known as Ahmad, Jamal, right? And then the person who's ever going to figure out, look at these two fellas, is forever going to mix up Jamal and Jamil. You get what I mean? But if you call Ahmad Jamal Ahmad from the beginning, and you call Ahmad Jamil Jamil from the beginning, you're less likely to mix them up. Right? Two girls, if both of them wear blue tudung at the same time, you're going to mix their names up, right? If it's the first time you're meeting them. If both of them wear the same baju at the same time, and then you learn both of them, you meet the both of them at the same time, the likelihood of you guys messing up their names is very high, true, no? If that's the first time you're meeting the two girls. This is the problem with this slide. Because now what you're going to do is, you're forever going to try to remember what the heck is rubeola. I don't know what's rubeola. I know rubeola is rubella. Or rubeola is roseola infantum. You're going to mix these two together. So this, don't make the association when there's no association to be had. Right? It's so much easier for you to remember that measles is measles and rubella is rubella. If this is the first slide that you see and the first time that you are trying to memorize the differences, you are definitely going to get mixed up. Right? Because all you're thinking is, oh, I got that slide in my brain that goes rubella, rubeola, and roseola. And then you never make the connection that rubeola is measles. It's actually measles. So when you learn measles, you learn that measles is measles, right? Don't even think about rubeola, but obviously you have to know that when people talk about rubeola, it's measles, right? Learn measles as measles, learn rubella as rubella, learn roseola infantum as roseola infantum. Right? Because if you link all of these three together and then you look at this slide like this and you try to memorize this slide, I bet you're going to mix everything up. Because rubeola sounds like roseola, sounds like rubella. Right? And in actual fact, all these three things, they are not that similar, and you should remember them individually by themselves first, by their different names. Right? So this is not a good slide. Definitely not a good slide. It would be a better slide if the person had changed that rubeola there and just wrote measles with no mention of rubeola. You get what I mean? Right? That would be a better slide. So what you should actually do is erase that rubeola and write there as big as you can measles. Right? If you're learning stuff, don't confuse yourself. As medical students, honestly, don't confuse yourself. There's so much facts that you can get that you need to memorize. If you do things like this, definitely you'll get confused. Right? Don't make things harder for yourself to remember. So just remember measles is measles. Just forget that it's rubeola for the time being. Until you get used to these are the conditions. Because honestly, I've been a pediatrician for like 10 years. I have never spoken of measles as rubeola. I have never heard my colleagues speaking of measles as rubeola. This is unnecessarily crowded. You're gonna make yourself get confused, right? Hanis, you got this slide from where? You found it yourself or is it from your senior slide? Because I've seen this slide like 3 times already. I've seen this slide in 3 different presentations in 3 different situations. This is from your seniors, is it? Hanis? Hanis?
Yes, Doctor.
Is this from your senior? Or do you come across it yourself?
Yes.
Okay, so basically try not to use this slide. If you want to use this slide, erase the viola, just write measles as big as you can ever.
Okay.
Okay, because this is unnecessarily confusing as well. Got it or not? Okay, this is how to kind of like this, but the other way lah. Right, the pictures, the pictures are fine. You want to see the differences, the pictures are fine, but you put, instead of using rubella, and rosella infantum, just put measles, rubella, and rosella. Right, because I know you're putting it there because it's a differential diagnosis for your fever with rash. But that's not the way to remember stuff. It's not a very good way to remember stuff. If you link everything that's so similar all together. Okay. Now, any other questions? No questions then. Then we can just stop here lah. Soalan tak ada? Kalau tak ada, then bye-bye. I'll give your marks to the administrator. I'll give your marks to the UIA staff. Don't worry about it. Okay? Okay, bye-bye.
Okay, thank you, Doctor.
Thank you, Doctor.
Doctor.
Thank you.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.